The skeletal system or skeleton is composed of bones, cartilage, ligaments, and but mostly the bones. And the skeleton accounts for about 20% of your body mass, and it's broken up into two divisions. The axial skeleton, which I'm going to do now, and the appendicular, which is in another video. The axial skeleton consists of about 80 bones. That's broken into three major regions: the skull, vertebral column, and the thoracic cage. And the axial skeleton has three functions. One of which is to form the longitudinal axis of the body that will connect the appendicular skeleton to it. It's also going to support your head and neck and trunk. In addition to, it's also going to protect your brain, spinal cord, and thoracic organs. So this picture here kind of shows the blue is the axial skeleton, and you can see the upper extremities attached to it at a pectoral girdle that we'll do in another video, and the lower extremities attached to the axial skeleton with the pelvic girdle that we'll go over in the appendicular portion. So you can see the back side of it and how it's attached. So the skull is probably the most complex of all the bony structures. And basically, I'm going to go through the parts on the handout that I gave you, which is of the axial skeleton. So the good thing about your particular textbook and most of the modern textbooks is that they have different bones colored differently. So for example, if you're looking at this from the front, that frontal bone is a mustard colored, and if you go to the side, you can see that you can still see the mustard colored frontal bone in front of the, I guess, reddish colored parietal bone. So all of the bones as you're going from any of these will be the same color so that you can follow it as a reference. But I'm just going to go through this in the list that I have there. And the first place to begin with is the orbit, which is where your eyeball would be. And so there's 7 bones that actually make up your orbit, but we're just going to start with the frontal bone. So underneath your eyebrows is a bony margin, which is called the supraorbital margin. So if you think about that, it's above your orbit. So supra means above, and orbit is where it is. And so the supraorbital margin is going to be underneath your eyebrows. In the center of your supraorbital margin is a hole or a notch. The hole would be the supraorbital foramen, and the notch would be the supraorbital notch. That's basically it. In between each of these supraorbital margins on the left side here and the right side here is a space that is called the glabella. The reason it's called the glabella is because of the sinuses that are underneath the supraorbital margin. Let me go to another picture so that you can see a sinus view of this. So here's what your sinuses look like. So if you look at, here is your supraorbital margin here. Here's the frontal sinus on the left side, and here is the one on the right side. And you'll notice that there's a space in between that does not have a sinus. And bony-wise, that's called the glabella. If you look at the sinuses of your skull, you can see the frontal sinuses, but if you go backwards, you can see the ethmoid air cells of the ethmoid bone, and also the sphenoid sinuses there in your upper cheek. So the purpose of a sinus is to, for a lot of us, make our lives miserable during sinus season, which is going on about now. But its purpose is to lighten the weight of your skull, but basically it is going to be an air-filled mucus-lined cavity. So that takes care of the supraorbital margin, the supraorbital notch or supraorbital foramen. The glabella is going to be the space between the two sinuses inside or outside of your skin. The next one that I have there is the anterior cranial fossa. The anterior cranial fossa is going to be an indent here, and it's going to be where the frontal lobes of your brain are going to sit. The middle cranial fossa kind of looks like a bow tie that's around here, and where the knot of the bow tie would be right there with the hypophyseal fossa of the sella turcica. And then the deepest one would be this one down here, which would be the posterior cranial fossa. Let me just show you what a picture of that looks like in a skull. So this picture here, I think, is drawing a little bit better than the colored one. So here at the anterior cranial fossa, the majority of that is going to be the frontal bone. Here's the middle cranial fossa, which is going to house your temporal lobes. And then the posterior cranial fossa has this big hole in the back. And so looking at it from a lateral view, you can see that the frontal lobes are going to be supported by the anterior cranial fossa. The temporal lobes are going to be supported by the middle cranial fossa, and then the inferior or posterior portion of your brain and also your cerebellum are going to be resting in the posterior cranial fossa. So that's a good way to see those pictures there. And that takes care of everything that you would need to know about the frontal bone. There's only like 5 or 6 of them, but just make sure that you can identify them based on a picture like this. Of course, when I give it to you as a practical, none of these words will be here, but the arrows with the lines will be going to whatever I'm asking you of. So that's bone number 1. Bone number 2 is going to be this reddish bone, which is posterior to the frontal bone, and it's called the parietal bone. The parietal bone in both this view and also this view is going to help make up the sutures. There's only 4 sutures that you have to know. And so the first one there, and like I said, I'm just going to go down the list here. The frontal suture or the coronal suture is going to be between the frontal bone and the parietal bone, and the zigzaggedy line that separates these 2 bones is called the coronal suture. It is also in the frontal plane. The second one that I have here is the sagittal view, which is going to be where the 2 parietal bones meet in the midline, and that zigzaggedy line that holds those 2 bones together is referred to as the sagittal suture. And the next one from there is called the lambdoid suture. That's where the 2 parietal bones meet the occipital bone, this brown one in the posterior aspect, and the zigzaggedy line that separates them is called the lambdoid suture. And so the lambdoid suture is responsible for, once you've reached maturity, that essentially is going to protect your brain. If you look at the last of the 4 sutures, there is going to be between the parietal bone and this orange bone there, which is called the temporal bone. And so you can see the zigzaggedy line here is separating the 2 of those bones, and that is called the squamous or squamous suture. So that's really everything that you need to know about for the parietal bones, is those 4 sutures that will be responsible for holding your skull together to protect your brain. You can see that there are other sutures, but for just beginning, you just need to know those 4 sutures. The next bone that's going to be on this list is going to be the occipital bone. Here is probably the best way that I can show you the occipital bone, and that's from the underside. So the most obvious part of this brown bone is this big hole there. And of course, big in Latin means magnum, and foramen means whole. So whole large is going to be the foramen magnum. So that is the first one that you have there. And on lateral to the foramen magnum, these things here that look like the bottom of a rocking chair are called the occipital condyles. The occipital condyles is going to be where your head sits on top of your first cervical vertebrae, which is called the atlas. So the foramen magnum is the easiest hole to identify because it is the big hole. And then the occipital condyles are the rockers that are going to be on top of the atlas of your spine. The next hole there is called the hypoglossal canal. And in this particular book, this is the only place that I can really show it to you. It is going to be superior to the condyle and lateral. So this hole here is called the hypoglossal canal. It is going to allow the cranial nerve 12 to go through it, which is the hypoglossal cranial nerve. So going down this list, the last one on this is the bump at the back of your head, which is the way that I think of it. So if you think of this external occipital protuberance and you reach around the back of your head and feel right in the midline, there is a bump at the back of your head. and that is called the external occipital protuberance. So you can see it a little bit here, and then in this midline thing, you could get to the foramen magnum. Lateral to that would be the occipital condyles, and then as we go a little bit farther, you can actually see the hypoglossal canal. That would be a little bit lateral of midline that would have the cranial nerve going through it. So next bone after that is going to be the temporal bone. And let's go backwards here a little bit so that you can see the temporal bone, which is this kind of orange colored bone here. Remember, it's going to be the inferior portion of the squamous suture after the parietal bone. But the point that I'm going to make here is this part here that goes to this blue bone, which is your cheekbone, which is called the zygomatic bone. So the zygomatic process is going to be this portion. Here is your ear hole. So this is where your ear would be. This one going here towards your cheekbone. So the way that a process is named is it's named according to the bone that it goes to. So this orange bone here goes to the blue bone, which is the zygomatic bone. So the process is named the zygomatic process of the temporal bone. Now, we're not going to get to this one, but from here, this blue bone that's going to this orange bone, this would be the temporal process of the zygomatic bone. By making it here, what we're going to do is create an arch. So there is a zygomatic arch that is actually medial to that zygomatic process. And so remember, this is three-dimensional. There'd be a bone or a muscle up here called the temporalis that will attach to this coronoid process of your mandible, and when it contracts, allow you to bring your lower teeth up to your upper teeth. So the zygomatic process is the process going towards your cheekbone. The zygomatic arch is the whole thing there, and then the mandibular fossa is the next one here. And on this particular bone, here is the zygomatic process. You don't see the zygomatic bone at all, but here is the process, and you can kind of see that there is a hole underneath it that is going to have a tendon go down to the coronoid process. This part right here is called the mandibular fossa. What you're going to have from the mandibular fossa is the mandibular condyle of your mandible going up there, making an upside down hinge. So for any of you who have a clicking in your jaw, it more than likely is due to your temporomandibular joint having had a problem there. Whether it was a car accident, someone hit you in the face, or you bit into an apple, or a hoagie sandwich too wide, you are essentially going to affect this. And what I usually tell my class is if you have a TMJ problem, put a dot in the center of your chin. In the bathroom, look in the mirror and see if you drop your lower jaw down, does it go straight up and down? Most people have it kind of shifting to the right or to the left. The mastoid process is the next one. Well, no, actually it's the external auditory meatus. It's your ear hole. That's all that really, so that hole right here and this hole right here is your ear hole without the ear. And that is the external auditory meatus. The pointy thing sticking down here is called the styloid process of the skull, because there's going to be a couple other styloid processes that will be in your wrist. And then the last one in this little area here is going to be the bump. So the bump behind your ear is called the mastoid process. This mastoid process should be hollow, and if you tap on it, it should have a resonance so that it's kind of like hollow, because it is going to be a sinus, same as you had your frontal sinus. So it is air-filled, mucus-lined, and hopefully you don't get a mastoiditis, which is an infection of that mastoid. So bone-wise, zygomatic process going to the zygomatic bone. The arch would be underneath that. The mandibular fossa is going to be that little cavity here. Posteriorly would be the ear hole, which would be the external acoustic meatus. The pointy thing sticking down is going to be the styloid process. And then the bump behind your ear is called the mastoid process. Let's just go back to the cartoon picture here, and you can see it colored: zygomatic process, external auditory meatus, styloid process, mastoid process, and all of those parts there. The next one, which is the petrous region, is a little bit harder to appreciate, and I have to get to the inside here, which is here. So this orange bone here is your temporal bone, and there's 3 holes in this one here. This one here, where we meet up with this orange bone and this brown bone of the occipital bone, is called the jugular foramen. So the jugular foramen is going to be a very, very large hole. And usually when I teach this class in the lab, and you can actually see this part by holding the skull, I'm going to say this is where my mountain climbing adventure is going to start, in the jugular foramen, and then I'm going to climb up this mountain. Inside of this petrous ridge here is going to be all of your hearing components, like the semicircular canals and the all the components that will help you to hear. So as I'm climbing up this mountain, right here is going to be the first cave that I'll come to, which is going to be the hole in my mountain climbing experiment, and this is going to be the internal acoustic meatus. Remember, the external acoustic meatus is going to be where your ear would attach on the outside of your skull. So let's just say I made it to the top of this peak here, and I fell off. As I fell off of it, I went into a jagged hole, and jagged in Latin means a lacerum. So if you have a laceration, it is a jagged cut, and so the hole which is jagged is called the foramen lacerum. You can't see the carotid canal on this particular one-dimensional picture, but if I keep going, I think backwards here, you can see it here. So the carotid canal is here, and so it is going to be from the underside. You couldn't really see that from the inside of the skull, but you can see the jugular foramen. It is a very, very big hole. The other one I want to point out here is also called the stylomastoid foramen. Here's the mastoid process here, and here is the styloid process. If you had seen this 3-dimensionally, you could see that there's a hole between the styloid process and the mastoid process, and it's an easy one to remember because its name is stylomastoid foramen. Foramen obviously means hole, and it's between the styloid process and the mastoid process. So this is the only picture that I can actually show you that one on that one. Okay, so next bone that we go to is the sphenoid bone, and in this particular textbook, it is the pink colored one that you can see from the underside, but you can also see it from above. Now remember, the top is taken off here. Here is the sphenoid bone, and then you can also see it from, or actually what it looks like. Here is what an actual bone looks like. So it has 3 processes. The 3 processes are going to be a bigger wing, which is called the greater wing, the littler wing, which is called the lesser wing, and the wings that hang down, because remember, this is going inferiorly, these are called the pterygoid processes. Okay, when I teach this in lecture, I usually refer to this as looking like a pterodactyl. And the only reason I pick that is there is no other word that I can think of that begins with a silent P, which is called pterygoid. So these pterygoid processes hang down, and if you follow them, they will bring you right to the back of your teeth. So the 3 processes that you need to be able to identify are the lesser wing of the sphenoid, the greater wing, which is this wing here, and obviously this wing over on this side and this side, and then the pterygoid process. There also is right in the center here. Now the book says it looks like a butterfly, but I think it looks like an angry bat. So where you could sit in this saddle here. So let's just say you were up here sitting in this thing, facing forward. There is actually a seat of the saddle, and it has a name called the hypophyseal fossa of the sella turcica. I don't know too much about the Middle East, but I do know that sella turcica means Turkish saddle. I've never ridden on a camel, but it looks like I could sit in this hypophyseal fossa. Put my legs on either side of this sella turcica and have my feet going into this jagged hole, which is called the foramen lacerum. So as I'm sitting in my hypophyseal fossa, I am going to have 2 holes that are directly going into my orbit, and they are called the optic canals. Okay? So even though it's very complicated, this bone, This bone is called the keystone bone because all of the other skull bones actually attach to it. And so let me move this camera a little bit so that you can see the names over on the side of some of the holes that I'm going to get to in a few minutes. So the problem with this particular bone, in addition to it touching every other bone, the greater wing, this wing that's over out here, has 3 holes in them. One of the holes is oval, so its name is foramen ovale, which kind of makes sense. Anterior and medial to that, so that's up and over, is another hole which is round. So foramen rotundum is the hole that would be anterior and medial to the foramen ovale. When I'm ever teaching this, I always try to find the oval hole first because it is unique and it is a very oval looking opening. The foramen rotundum, rotundum in Latin means rotund or round, and so the round hole, the oval hole, and then posterior and lateral to that hole is a hole that is called the foramen spinosum. Spinosum actually means spine-like, but it doesn't work with my analogy, so I'm just going to call that the tiny hole. So if we go forward to actually look at these sphenoid bones, you can see here is an oval hole, that's the foramen ovale. Here is a round hole, that's the foramen rotundum, and then posterior and lateral to that one is the foramen spinosum. So in the greater wing, you are going to have 3 holes, and they are quite identifiable, and you can see it on here: oval hole, tiny hole, and a round hole. So rotundum, ovale, spinosum. Some of the things I'm not going to ask you, there's a separation between the lesser wing and the greater wing, and it's this fissure right here, which is called the superior orbital fissure. So that takes care of the sphenoid bone, which is a god-awful bone to actually see it in real life. The next bone is called the ethmoid bone, and the ethmoid bone is just as weird as the sphenoid. If you could take off your nose, as you kind of see it right here, this is the deepest bone that would be in your face. And so the ethmoid bone kind of has a straight line going up and a straight line going down. The part that sticks up here is called the crista galli. So if you remember in this anterior cranial fossa, most of it's going to be the frontal bone, but there's a part right in the center that is not a frontal bone. And that's where the ethmoid bone has its crista galli sticking up. And so if we follow this straight down, this part here, which is going to make the superior portion of your nasal opening here, is called the perpendicular plate of the ethmoid bone. There's a bone that's going to attach to it here, which is called the vomer bone. So the vomer bone here attaches to the perpendicular plate of the ethmoid bone. And if everything worked out perfectly, you'll have one nostril the same size as the other. If it did not, and you had one of these bones slightly twisted, you have something referred to as a deviated septum. And you might have one nostril a little bit larger than the other, in which case they may go in and actually break your nose bone so that they can line it up so that you can breathe better. The good thing is insurance companies will pay for that, because if you're snoring, which will happen if you have a deviated septum, you're also going to have an increase in blood pressure. So if you think of this as just a straight line up and down with the crista galli here, and the crista galli has an important thing because that's going to be an anchoring point for your brain's outside covering, which is the dura mater, to anchor it into the brain. So when it's sticking up, you are going to have the outside of your brain sticking onto the crista galli. So that means when you're beating your head against the wall, your brain's not sloshing around too much. And so if you just think of that, and then everything to the lateral of it on this side and that side are going to be something called lateral masses. The lateral masses that you can see in this hole and this hole here are riddled with holes. They are called the ethmoid air cells. They are a type of sinus. And if you get a true sinus infection that goes from your frontal sinus into your ethmoid sinuses and then into your cheekbones, you are miserable. The only thing I want to mention with this, the most lateral portion of the lateral mass is called the orbital plate. So the orbital plate here and here is going to be the medial portion of your orbit. The only thing I didn't mention is the holes that are a little bit here and that is called the cribriform plate or the cribriform foramen of the cribriform plate of the ethmoid bone. So this particular bone, which is so deep in your face, is going to be responsible for having, in addition to everything else that I mentioned, on top of here is going to be the olfactory bulbs. And so because these are holes, and as smells go up your nose, it goes right into the first cranial nerve, which is the olfactory cranial nerve, and that's where your brain will then sense smells. And so just bringing it back to the picture again, here is the perpendicular plate of the ethmoid bone. Here is going to be one nostril and the other nostril, and here is the vomer bone, which is going to meet up with the perpendicular plate of the ethmoid bone to make up something known as your nasal septum. Remember, it's going to have cartilage over the top of the bone and then skin over that, and so that's what's going to make certain that you have a nostril, hopefully that's not deviated. Next bone we go to is your mandible, which is probably one that a lot of you are familiar with. It is actually easy to draw, although I don't have a chance to get it to draw anything here. So the mandible is your lower jaw. It is a upside down hinge. And so the mandibular condyle here goes into the mandibular fossa, which was in the temporal bone, and that's your upside down hinge that you can kind of see here. So the mandible is pretty straightforward and easy. Everything that goes from your angle of your mandible to the front is called the body of the mandible, or mandibular body. Then here is the angle of your mandible, or mandibular angle, and then as it comes up, this part here is called the ramus. So the ramus is going to have two processes. In the posterior portion, it's going to have the mandibular condyle. So this should actually say mandibular condyle, which is a process. And then the anterior one would be another process, which would be the coronoid process. So if you remember, the coronoid process would be here, the muscle would be here, and then the tendon would go underneath the zygomatic arch to connect to the coronoid process. When you contract that, it's going to bring your jaw up, your lower teeth up to your upper teeth. So just kind of going around this thing in a circle, the mandibular condyle will go into the mandibular fossa. The ramus of the mandible is going to be this portion coming down. Once we hit the angle, we're going to go anterior, and that's the body of the angle, or the body of the mandible. There's going to be two holes, one in the front, which is called the mental foramen. If you remember, the tip of your chin was the mental region. And then there's going to be a mandibular foramen on the inside of each of these ramuses. So you can see back here a little bit how the temporomandibular joint is put together. Here is the temporomandibular joint. Here is the mandibular condyle going into the mandibular fossa, and you still have the coronoid process sticking out here. The last thing that we have on this are your teeth. So if you take each one of these teeth out, there would still be a hole in the bone, which is called the alveolar, or the socket is called the alveoli. The alveolar margin used to be the bony margin that would surround the tooth, and you can kind of see it going up and around and all of that. And the same thing is going to happen in the maxillary bone. But just as you're looking at this, and just some weird thing about me, one of the things that I do is I eat kernels of corn one row at a time. So if these were kernels of corn, what we would do is take out a kernel, a kernel, a kernel, a kernel, a kernel. I'd eat that row, and then I'd move over and then eat the next row. That gives me an example to show you that where I took the kernel of corn out, which is going to represent the tooth, the indentation in the cob is going to be what is referred to in bones as the alveoli. So the alveoli is going to be the hole that would be in the bone where the root of the tooth would go into. So that's basically everything with the mandible. Going back to another thing so you can see it from the front, there is, in this particular textbook, the mandibular symphysis, but your lab book has a different name for it, and I have to go look that one up because I haven't remembered that, and it is called the median. technical difficulties. I think it's the median mental something. Anyway, can't find it. Anyway, so that's it for the mandible. The maxillary bone, or the maxilla, is this purple bone right here in the center. It's going to have the same features of the teeth that you had in the mandible, but they are going to just be for the maxillary thing. So the alveolar margins, one of the things that I wanted to point out for you, so here is the orbit, and here is the supraorbital foramen. Underneath the orbit is right here, and that's the infraorbital foramen. Okay, so what you want to see or notice is that this portion of your cheek goes out towards this blue bone, which is the zygomatic bone. So this would be called the zygomatic process of the maxillary bone. Okay, I don't think you have to know that one at all, but let me just flip to the inside of this so that you can see this is upside down from your spine looking up to this. These are your two front teeth, which are called your central incisors. These hole right behind your two front teeth is called the incisive fossa, or the incisive foramen. And then once again, the whole roof of your mouth, this green bone here, is called the palatine bone. And essentially, remember, those processes are named according to the bone that they're going towards. The whole roof of your mouth, until you get to as far back as your tongue will go, is called the palatine process of the maxillary bone. This is actually called the maxillary bone. This one from underneath is going to be called the vomer bone. So if you remember when I was talking about the sphenoid and the wings, so if you follow the teeth to here, this one and this one here are the pterygoid processes of the sphenoid bone. And of course, off to the side, you can see the greater wing on either side of them. And of course, our three holes, the oval hole, which is the foramen ovale, and the small hole after that, which is the foramen spinosum. So for this maxillary bone, most of the roof of your mouth is made up of the palatine process of the maxilla as it goes towards the palatine bone. Just get back to this one. Same thing here. Here is my nose. Now remember, most of my nose is going to be hyaline cartilage. My nose bone doesn't start until about an inch from the tip of my nose. And so these nasal bones are these two bluish, dark blue bones here. And I do wear glasses, as I put my glasses on, I never really have the little portion of my glasses resting on this. They're usually resting on either side. And if you notice, here is the maxillary portion going up to my frontal bone. So this portion of the bridge of my nose is the frontal process of my maxillary bone. And basically, that's probably where I rest my glasses on, and going into the green bone here, which is the lacrimal bone. The only part you really need to know from the lacrimal bone is that there is a lacrimal fossa that I'll show you in another picture of where it's going. So the maxillary bone is your upper jaw. It also has a sinus. Most of all of the upper portion here is the sinus, as I showed you in that sinus demonstration a little while ago. And you can see the majority of what you need to know is from the underside. So once again, we go to the zygomatic bone, which is going to be your cheekbone. It is these dark blue bones on either side. And remember, they're going to have a wing portion from your cheek going out to the zygomatic bone. And you're going to have it on the side from the temporal bone going towards the zygomatic bone. The next bone that I have is the nasal bone that I just talked about. The lacrimal bone is these green bones on this particular book. And let me just show you that the only part that you need to be able to identify on this one is the lacrimal fossa. That's where your lacrimal sac is going to go into, and then it's going to drain into your nose, which is the beginning of ANP2. Vomer bone, we already mentioned before, and the last bone that we have in this particular section in the axial skeleton until we get to the spine is called the hyoid bone, and I'm just going to show you what this one looks like. And the hyoid bone is in your neck. If you get on Jeopardy and they ask you what is the only bone that does not form a joint with any other bone in the body, it is the hyoid bone. Some of the other pictures that this particular text does show you, the inferior nasal conchae is a separate bone by itself. And you can here see the perpendicular plate. This is in a mid-sagittal view as it goes into the vomer bone. And so that's what's making up your nasal septum. And of course the cartilage that's also going to be there. So that ends the skull. The next one that I'm going to do is going to be the vertebral column. And I think it's on this disc, so I can just keep going. And there's the nasal sinuses. Nope, it's on the next disc. So just kind of hang out for a second, and I will bring up the second one, which is going to be the spine. Which, believe it or not, a chiropractor should know a little bit about. So the spine, or the spinal column, or the vertebral column, is a series of 26 irregular bones in 5 different regions. When I went to school, we had 7, 12, and 5, and that's how they used to say meal times. So you would have breakfast for cervical, thoracic would be at 12 o'clock, which is 12, and lumbar is going to be 5. So 7, 12, and 5 still hold true. And then, of course, Taco Bell invented 4th meal, and that's going to be the sacrum, which is going to consist of 5 bones that have fused together. And I'm going to go through all of them and at least let you know what you're supposed to know for this practical. By having these curves, we're going to have the head up here, then we're going to have a cervical curve with the concavity going posterior. We're also going to have a lumbar curve with the concavity going posterior. The thoracic region has the concavity going anterior, as does the sacrum. So by doing that, you are giving your spine, and particularly your brain, a shock-absorbing ability to, survive bouncing and stuff like that. And so, as we talked about a little bit when we were doing the discs that are between the vertebrae, and I know a lot of students always have and ask questions about that. Can discs actually slip? Believe it or not, they can't, or they're not supposed to, because we got a heavy ligament in the front and a ligament in the back. And usually what I tell my patients is each one of these discs are like a jelly donut. And so that's a picture of the anterior longitudinal ligament, which is really, really heavy, and it's not going to allow the disc to go forward, but it might go backwards. So this particular view here is showing you of the nucleus pulposus and the annulus fibrosus. What that means in English is the nucleus pulposus is the jelly of the jelly donut, and the annulus fibrosus is the donut of the jelly donut. What it would mean if you have an injury. So if you have a disc that protruded, so this is going posterior, this jelly donut is having a little break in the donut portion, and you can see the jelly here herniating or protruding and putting pressure on this spinal nerve going off to the side. So in that particular picture there, looking at it from the top down to the bottom, that is called a herniation of the disc or prolapse of the disc. What it would look like on an MRI is this picture here. So whereas this is like a jelly donut, jelly donut, jelly donut, jelly donut, this one here, it looks like the jelly is leaking out of the jelly donut, and this is at L5S1. So we're not in the spinal cord. So this herniated nucleus pulposus is putting pressure on this leash of nerves, which is going down your leg, which is probably going to be the sciatic nerve. And so that's why you get a lot of pain going down your leg, because that jelly that's leaking out of the jelly donut is putting pressure on that leash of nerves going down your leg. And so this particular text says, you could have physical trauma, you could fall down a flight of steps, have a car accident, and you can have one or more herniated, prolapsed, protruded discs. All it really means is that you have some of the jelly donut leaking out of the donut itself. And by putting pressure on the nerves, it causes numbness and excruciating pain. You may want to put another adjective to that. The other thing that we cover is the 3 major differences that can happen to your spine. What's going to always happen is hopefully your head is going to be over your pelvis. So in this particular girl who has scoliosis, you can kind of see it curves to the right and then to the left. Sadly, it is mostly females who get scoliosis. When I used to work as a neurophysiologist, we would always go to the operation, and some of the operations, some of these girls were like 10, 11 years old. That's why they have you go to middle school, to go to the school nurse, to have you bend over at the waist so that they can look down your spine. And most of the time they're looking for something called rib humping. And if you look at this particular girl's right side, when she bends over, this whole right side is going to stick up. And so, although medicine is cruel in describing it, what they do is once it reaches 60 degrees of curvature, they will then put rods going down her whole spine. And it's kind of interesting to see how that works. I did have a student a couple years ago who was a guy, he was 20, he had had a scoliosis, and he had the scoliosis right after we had taken a break from fall going into the spring semester. He actually took the spring semester off. But I said, you know, I know what's going to go on in the operating room because I've been in many of them. I said, how much pain were you in? And of course, he was in a lot of pain because and there's not much bleeding because they cut through all of these muscles here and they do electrocauterization, which means as they cut, they're also fusing it together. And he said he had had so much pain as a 20-year-old that he was willing to do anything. And he said he stands up straight because he has 2 rods in his thoracic region. But he said it did hurt a lot, you know, there was no getting around that. And usually they'll do it with these girls at a very, very young age because it could have been they checked it out at 10 and the next year they'll measure it and it's gone from a 10 degrees curve to a 30 degree curve. So idiopathic scoliosis means, idiopathic by definition means we don't know why it happens. It just happens. The second one there is a kyphosis. Once again, this is going to approach or affect a lot of females, usually at menopause. At menopause, what's going to happen is you're going to leach out a lot of calcium from your bones. And in her particular case, I would guess that the anterior thoracic bodies have collapsed. And so she has got what's referred to as a dowager's hump. Once again, medicine is cruel in describing it, but this particular woman probably cannot straighten those bones up at all. And the last one, although it says lordosis, which is a normal curve, in her particular case, I'm assuming she's pregnant. And so when you have little Junior in front of you, you are putting a lot of pressure on your spinal processes in your back. And so as the baby grows, of course, it is going to give you more and more pain just because you have all of that affecting your spine. So you do need to know this thing here, which is a typical vertebrae. And so I'm just going to go off of this one. Here, although it says body, it is the vertebral body or body of the vertebrae. That is what everything should be stacked upon. Coming off of that are going to be pillars. They are called the pedicles. The 2 pedicles will then go off laterally, and that is called the transverse process. This particular spine is actually from a thoracic region, and I'll explain that to you in a few minutes. And then in order to make the ring for the vertebral foramen, we're going to go from the transverse process to the spinous processes, which is the bump you can feel in your spine as you put your fingers down your back. And this portion here is called a lamina. So we're going to go from the pedicle to the transverse process to the lamina to the spinous process and do it on the same way on the other side. And by doing that, we'll make something called the vertebral foramen. And then in this portion, which is the thoracic region, that's where your spinal cord would go down. Your spinal cord ends at about L2. So if you get down into L3, L4, L5, it is not the spinal cord. It is those leash of nerves that you saw on this MRI. And I'll go back to that so you can see it. So this is 5, 4, 3, 2. So the spinal cord would end about here. And then everything that goes down here is going to be some branch of the spinal cord. More than likely that'll go to down your leg. And so it's kind of interesting. So I'm just going to tell you about each cervical, thoracic, and lumbar region because they all are uniquely different. So if you want to think of the spine as supporting your head, the cervical region is going to be the smallest. It is also going to have a bifid spinous process, and it's also going to have a transverse foramen, a hole in the transverse process. So the reason for that is so that the vertebral artery can snake up through that and go up to your brain. The other thing I'd like to point out, just looking at this, looking from the top, looking down, the vertebral foramen in the cervical is going to be an upside down D, as will the vertebral foramen in the lumbar region, whereas the thoracic one is a perfect circle almost. So the parts that you would need to be able to identify are the spinous processes, which is going out posteriorly. You can identify the transverse processes, which is in the side going out, but there's a transverse foramen inside of that. Here is, of course, the body of the vertebrae. And then when we look at it from a side view, we're going to have the spinous process. Once again, you'll see the bifid spinous process here, the little tiny body because it's not supporting anything more than just your head. But you're also going to have a superior articular process and an inferior articular process. And here, of course, is the transverse process going off to the side. So the inferior articular process of this vertebrae is going to form a joint with the one underneath it, superior articular process. So if you think of them like a bicycle chain, you're going to have the one from above joining up with the one below it. And so that's the cervical portion. The thoracic, I'll just start here, is going to have the same parts, but some of them are going to be uniquely different for the ribs that are going to attach to them. So you can see the superior articular process, and then there would be an inferior articular process that you can see here. There's also on the ribs, or excuse me, on the thoracic vertebrae, where the ribs are going to attach to, and I'll get to that in a few minutes. But the spinous processes are all long and pointy. And so that pretty much makes up, and of course, if you go back to this one, it has almost a perfect circle for a vertebral foramen. You can see the superior articular processes because this is looking from the top, looking down. And you can see the facets because the ribs are going to start here, curve around, and then come around to the front. By being on the lumbar one, which is going to be bigger because it's now supporting more weight, you can see the spinous process, you can see the transverse process, a much bigger body, and an upside down D for a vertebral foramen. When you look at it from the side, the spinous process is going to look like a hatchet. And, so basically you can see that all of these are going to be responsible for being stacked on top of one another. So the only two vertebrae that are actually have names that you'll have to ever know about is going to be atlas. So if you remember, atlas holds up your skull. So the occipital condyles are going to sit on top of this thing here, which is the superior articular process of the atlas. The unique feature of an atlas is it does not have a body. Let me just go to here. So here is anterior. Here is where the body would have been, but there is no body. You're actually going to have a part of C2 sticking up through here. You can see the lateral masses on either side. You can see the transverse process and the transverse foramen. And you can see this big superior articular facet that's going to receive the occipital condyle because you're going to stack your head on top of C1 or atlas. There is no posterior spinous process at all. It just has a little knob, which is called the posterior tubercle. And in the front just has a little knob also, which is called the anterior tubercle. From the underside, once again, here's the posterior, here's the anterior. And then so this inferior articular facet is going to form a joint with the superior articular facet of axis, which is C2. And you once again can see the transverse process and the hole in the side. And so when we get to axis, now you're starting to see the spinous process. Although you probably won't see it too well in this view, it is going to have a bifid spinous process. So this part here that looks like a thumb sticking up, which is this picture here, is called the dens. It is also called the odontoid process that I think I put in there. But just so you get the idea, it's where this part sticking up would have been where the body of the vertebrae of C1 would be. So here is C2, you can see the bifid spinous process, and here is this thumb sticking up thing here. That is going to be where the body of the atlas would have been, but it has no body. And so just keep that in mind. And then everything else, C2, C3, C4, C5, C6, all are going to be a typical vertebrae, which would have a typical bifid spinous process. It would have a typical hole in the transverse process, and they're tiny. I did mention it in yours that C7 sometimes does have a name. It's called the vertebral prominence. And the reason that they call it that is because you're making a curve one way and then another curve going this way. And so this particular vertebrae may or may not be bifid because it may take on some of the characteristics of a thoracic region. But as you have them all stacked on top of each other, you can kind of see that atlas and the occiput is what's going to allow you to nod. And the beginning of turning your head from side to side is going to take place at the atlas and the axis. That first starting to turn is going to take place at those articular facets. Thoracic vertebrae, look, as I showed you before, long and pointy. The unique feature of these is going to be each of these are going to have a rib attached to them. So as you look at them, here is the superior articular process, and here is the transverse costal facet for the tubercle of the rib. And so these are going to then make a unique feature, which is going to be your, I don't know what happened here, went all the way, I'm going to go backwards. I think this is what I wanted to show you here. Here is the body of a thoracic vertebrae. Here is the head of the vertebrae. It's going to be between two vertebrae. And then here is this costal facet, and it's going to receive this rib here. The rib tubercle forms a joint with the transverse process. Let me just go backwards. And so this is actually a good picture of it here. Here's the rib between two vertebrae. It has a demifacet or facet here, and it's one on the inferior portion. So the head will be between the two vertebrae. And then as it curves out, this portion here, which is the rib tubercle, will form a joint with the transverse process. And then as it comes around, the hyaline cartilage at the end of the rib will then attach to the sternum. So we're going to get to that one in a few minutes. So these are the characteristics of the thoracic vertebrae. The lumbar vertebrae, remember, these are going to be bigger, and they are going to be going 1, 2, 3, 4, 5. Cervical, 1, 2, 3, 4, 5, 6, 7. Thoracic, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. And they're all going to have a rib attached to them. And then 1, 2, 3, 4, 5, they all kind of look like that. They're blocky. The spinous process does look like a hatchet. And so basically that's how we are going to attach them all from one place to the next place. That brings us up to the sacrum. And a few years ago, the way that I taught this is a little bit different than I do now, because one of my kids was watching Dinosaur Train. And I thought that on Dinosaur Train, the back or posterior portion of the sacrum looked like a stegosaurus. So it's always amazing where you learn things. And so I started teaching it this way because the anterior portion of a sacrum, even though it has the same hole, these two holes here are called the anterior sacral foramen. And if you follow where those are, on the posterior side, which are these two holes, it has a different name. So how can I get students to remember that? Well, I kind of came up with this idea that there was a nuclear holocaust, and when all of these, the nuclear holocaust happened, all of these discs fused together. And so on the anterior side, there is no longer a disc, but there is what they now refer to as a transverse ridge, which used to be called a transverse line. It means it's going from side to side. And if you think of that nuclear thing happening, All on the anterior side, these things are now, where they would have had a disc, are now referred to as a transverse ridge. On the posterior side, remember the dinosaur side, the same thing happened in the spinous processes. So the nuclear meltdown happened, and all of these, where you would have had in the lumbar section, you can see all of the spinous processes in the midline. And remember, midline, exactly the midline is called median. All of those spinous processes fuse together to make something called the median sacral crest. So you just have to listen to my silly story to try and remember this. Lateral to the median sacral crest is going to be holes, and the holes on this side are called the posterior sacral foramen. Or on the anterior side, they're called the anterior sacral foramen. So there is a difference between the anterior versus the posterior side, even though they are the same holes, and as you see them. So we got the median sacral crest, we have the posterior sacral foramen, and then all those transverse processes during the nuclear meltdown fuse together, and that's going to be referred to as the lateral sacral crest. Once again, how are you going to remember all of this stuff? Make a silly story up, and that's a good way to remember it. And then here is the auricular surface of this sacrum. The auricular surface of the sacrum is going to meet up with the auricular surface of the ilium, and it's going to make a joint called the sacroiliac joint. So the ala is just wing, don't worry about that, but you can see the superior articular process on either side is then going to meet up with the inferior articular process of L5, and these are going to go in a coronal fashion, whereas most of the spine goes in a sagittal one. The hole at the top here is a continuation of the vertebral foramen, and in the sacrum it's known as the sacral canal, and the hole on the inferior portion, break in Latin means hiatus, so if your favorite TV show took a break, they went on hiatus. But because hiatus means a break, the break down here is called the sacral hiatus. So we have the sacral canal up top, we have the median sacral crest, and at the bottom of the crest is called the sacral hiatus. Once again, midline fusion is called the median sacral crest. Then you have the posterior sacral foramen. Then you have the lateral sacral crest, and then lateral to that will be the ear. That's going to meet up with the iliac's ear, and the two auricular surfaces are going to meet together. The coccyx, which is your tailbone, is usually going to consist of, depending on the textbook, 3, 4, 5 particular bones, and I have it as 3, 4, 5 rudimentary vertebrae. Usually, if you have more than that, when you're born, they'll probably cut it off, or make sure you don't have a tailbone. So that brings us to what I alluded to before, and this is also in the axial skeleton. This is called the thoracic cage. Thoracic cage is going to consist of the sternum, and there's 3 bones that make up the sternum, and the rib cage that's attached to them. The 3 bones are considered to be the manubrium. Then there's going to be an angle that will go to the body, and it just says body, but it should be body of the sternum or sternal body, which will have a joint, which will then go to the xiphoid process. So as you just follow that down, the sternum begins with the manubrium, and it really, manubrium means badge in Latin, and it really does look like a little badge. So we got the jugular notch in the front. We're going to have the clavicular notch here, and that's where the clavicle or collarbone will attach to that. Then we're going to have the sternal angle, which will then go to the body of the sternum, and then we're going to have the xiphi-sternal joint, which will go to the xiphoid process. The xiphoid process is mostly cartilage when you're young, and then as you get older, it starts to turn into bone. So that's going to be that portion of the sternum. Then there's going to be 12 pairs of ribs, so that gives you 24. The first 7 pairs are all going to have a sternal or a cartilage attachment to the sternum. So if we count them, 1, 2, 3, 4, 5, 6, 7, and you follow this cartilage up, it goes to the very bottom of the sternum, at the body of the sternum, just before the xiphi-sternal joint. So they are considered true ribs because they make an actual attachment to the sternum. The false ribs are the ones that don't. And so most of you probably know about rib 12 and rib 11. They have no anterior attachment and they're referred to as floating ribs. But ribs 10, 9, and 8 are considered false because their cartilage attaches to the cartilage of rib 7, which is a true rib. So ribs 10, 9, and 8, their cartilage attaches to the cartilage of rib 7. And so that's why they're considered to be a false rib. So just kind of going over the bony portion of the thoracic cage, you have in the midline the sternum, which consists of the manubrium, the sternal angle right underneath it, the body of the sternum, and then right underneath is the joint that attaches to the xiphoid process, and that's the xiphoesternal joint. Ribs 1 through 7 on both sides, so 14 ribs will attach directly to the sternum. As you can see here, they go right up to that. And then ribs 8, 9, and 10, cartilage will attach to the cartilage of 7, and they are considered false ribs because there's no direct attachment to the sternum. And then ribs 11 and 12 are just considered floating ribs, and they are basically there to protect your kidneys a little bit. So really, the ribs itself are pretty straightforward. And so as I showed you before when we did the thoracic portion, there's not a whole lot of parts. There's going to be the head, there's going to be a neck, which is a narrowing after the head, then the rib tubercle, and then this whole long thing, which is called the shaft of the rib, or the rib body, is going to make a cartilaginous attachment to the sternum. And then you can kind of see the parts in this one a little bit better. Here's a thoracic vertebrae. How do you know that? Well, it's got a perfectly circle. Here's going to be the head of a vertebrae attaching to the body. And then here is going to be the transverse process. And of course, the rib tubercle attaches to the transverse process at this flattened little area there. So it shows it to you pretty well. And here's a typical rib 6. Not that you're ever going to have to identify it as rib 6 or anything like that, but you can see all of the parts that make up the rib itself. So that completes everything that we have for the axial skeleton. Once again, if you have any questions, feel free to send me an email. And good luck studying all of this stuff.